The Russians make super villains. The ones make superheroes. They do. See? Don't pay it.
ya ce yanzu So, good morning, everyone. Good morning, everyone.
Morning, sir.
Yes. Can we see the slide?
Yes, sir.
Yes, we can see it.
We can see it, sir.
Issues with restriction of movement in Kano because of sanitation. There is sanitation at every Saturday, last Saturday of the month, and there is restriction for us to move to the hospital for the workshop. So sincere apologies. Now we can start proper. Please, I need a response from audience that if there is anyone who did not attend the last week presentation or workshop, so that I will know where to start. If all much of the time today, so that we'll just go straight to build on what we did last week. Please, anyone who was not here last week, please, maybe you just unmute or you just write message. Like I can see, somebody has responded. 2 people.
I wasn't in the meeting.
Okay,
I was in the
3
meeting last week.
4. Wow. So, because if I commence with the lecture today, 5, 6, 1, 2, 3, 4, 5 members with the audio, 6, around 6 members out of 30 I can see online. Didn't attend, almost 7. We're heading to 10, almost a third of the audience. So it appears that we have a new audience completely. Okay, so that means we have to revise. Okay. Because the topic of today is majorly we are supposed to look at the very few techniques that we didn't consider last week, and then we go ahead to discuss GATE facilitation using PNF. Then we'll also discuss math exercises using PNF. But sincerely, if especially this is the first time somebody is attending PNF class or workshop or seminar, I think it's very difficult to understand what we are going to do today. And I think since majority, I didn't hear from others, but I can see all the comments here are for people attending fresh today. So please, if others can permit me to go back and rush through, then because I want to be able to discuss the scope of today, so that I will not just repeat last week workshop. I don't know, because there are maybe others that wanted to get a new, additional information from last week. So sorry, so I believe almost all the attendees today are from, are fresh. Maybe the flyer, maybe the last week members thought that is everything was covered last week. I think that is what they thought, because it was divided into 2, because it's not possible to take the other half last week. I think we finished around past 4 p.m. and a lot of things have not been discussed. Okay, so I think let's just go back and discuss. Last week we started by defining. There's a synopsis which we are going to go through, which introduction, brief history, philosophy, assessment, and principles of PNF. So don't worry, we'll see what we can add today. Yes, there are techniques which you have agonistic techniques. That is what we discussed last week. Agonistic techniques, antagonistic techniques, There are also relaxation techniques, hold relax and contract relax, which we are supposed to take today. Then there are patterns, which we also took last week. The definition of the patterns, the scapular and pelvic patterns, upper and lower limb patterns. We've taken them last week also. Then documentation of PNF concept or PNF approach. I started by showing this picture that that I see. I don't know in other parts of the country or in the other part of the world that we mix up passive movement and PNF. That sometimes you even see documentation written PM/PNF, meaning both of them. I mean, they are similar or similar things have been done, or maybe thinking they are the same thing. And I'm trying to tell us here that these are not the same thing, that they are entirely different thing. In fact, passive movements could be part of PNF too, because there are some techniques that you have to apply passive movement, sometimes active assisted, active resisted, and so on. So PM, if you write PNF, maybe even okay, instead of writing PM/PNF. And we had a lengthy discussion about that. So yes, I also jokingly said that PNF is another meaning is people need fun. There is a lot of fun in doing the PNF, even though there's a lot of confusion also. But there is what do you call it? This saying. There's always the darkest night before the dawn. So there'll be a lot of troubles, confusion, but with time, things will get better and you begin to enjoy managing patients with PNF. Of course, it's very fun to use PNF. I enjoy it a lot. So starting by definition or history, sorry, PNF was developed by Dr. Herman Kabat, who is a physician and also a physiologist, and together with Maggie M. Knott, who is a physiotherapist. Around 1940s, they developed this concept of PNF, but initially it was termed proprioceptive facilitation, not PNF. Until later, the term neuromuscular was added. This is a picture of Herman at his later age. Then Maggie Knott at her earlier age. This is a picture of Herman looking at his younger age with Dorothy Voss. We could see they are applying PNF technique there. This is a combination of patterns, upper limb and lower limb pattern. And we could see there that is diagonal 1 pattern for the diagonal 2 pattern for the diagonal 1 pattern for the upper limb into the direction. So they are having these exercises together. So this lady, Dorothy Voss, is the one that introduced the neuromuscular into the nomenclature. That's when we have proprioceptive neuromuscular facilitation. Initially, it was just proprioceptive facilitation. It was the lady, Dorothy Voss, that introduced the neuromuscular. Then later on, still in the 1940s, a Kaiser-Kabat Institute was established, like I said earlier, in Washington, D.C. This is established and funded by a wealthy industrialist called Henry Kaiser. And the reason is because he had a child with poliomyelitis, and he wanted to see how his child could get better. He's rich, he has all the resources, and he funded the establishment of the institute. So that's why among the early conditions that were used to manage for PNF to use PNF to manage was poliomyelitis, then followed by multiple sclerosis. So they later on moved to California and developed. That's when the treatment techniques and procedures were developed. Then all these techniques they were developed based on the Sherrington's principles, which we are very much familiar with as physiotherapists from our physiology and also from our exercise therapy. We know all this reciprocal inhibition phenomenon of irradiation, successive induction, and so on. Then continuation with the history is another institute. So it's getting interesting. It's getting people getting interested, bringing in their children for management and so on. So the institution are expanding beyond just one institution. Then in the 1950s, 56, first PNF book was written and published. Then courses are now taught later. So that is also how I got to learn PNF. I attended international course of PNF, which is awarded by IPNFA, International PNF Association. So the course moved from United States. It spreads across Europe. And the first course taught in Europe was taught by Maggie Knott herself in the 1960s at Switzerland. Then 1978, Maggie Knott passed on. And this is just the brief history. So IPNFA was established in the 1990s. This is the institution that this is the association that certify all institutions that provide certificates for trainers or for individuals to practice PNF. Yes. So by definition, proprioceptive is to stimulate sensory receptors. Then neuromuscular is activating neural tissues, and facilitation is to make easier or more effective while management. So the term PNF is, as people used to say, is not PNF technique or PNF this and that. Appropriate term is you say PNF concept or PNF approach rather. Anyone will fit, but not PNF technique, because we could see here technique is one aspect of the concept. We have the philosophy, the basic principles, we have the basic techniques, we have the basic movement patterns, we have the gait rehabilitation, we have the math exercises. In fact, there are even more. We have breathing exercises for PNF. We have facial exercises for patients with facial palsy and other problems related to the face. So PNF is very wide scope, and it's not just for neuro or for neuro conditions. It can be applied for orthopedic conditions. It can be applied for pediatric conditions. It can be applied to so many conditions, not just neuro. Maybe it's just the name neuromuscular. Sometimes there is, although majorly the conditions are managed by using PNF neuro, but other conditions too are also possible. So we'll go straight into the concepts. Then we discuss the philosophy. The philosophy of PNF is always that it should be positive approach, that the approach should be positive. Yes, that you always look for the good side of the patient. What are those things that he has that are if it's just a little function that you'll be able to trace for that patient, you should be able to improve that function. Not looking at what the patient cannot see, like we document, patient cannot sit, patient cannot stand, patient cannot walk, patient cannot do this and this. What are those things that the patient can do? Those are the things that you look for and improve on them. Those little things are the ones that will add. So PNF is always pain-free also. When there is pain, you always look for better way, better position, technique, pattern, and various applications on how you can do it without pain. Then apart from positive approach, we have the mobilization of patient reserves. Just like what you have said earlier, how do we do that? We do that through active participation. In a philosophy of PNF is that patients should always be active. You should be active by looking, watching, or mentally active, mentally participating, or physically participating with the limbs, but the patient has to be active all the time. And to mobilize the reserves also, we'll have to make it very intensive and also multi-dimensional. Like I said, you change position, you change activities, you change whether it's in sitting position, you go to standing position, or you go to mats, or you go to couch, or various positions, or it should be in supine or pro line or sideline or various positions. You just make sure, and it should be activity related. It's not just you applying the PNF, but you make sure that is in line with the activities of the individual that he wants to learn. Then you should make sure that when he goes back home, he continue with these things, and he's doing it by himself with family members, or maybe other physiotherapists going home for follow-up management or home program, and so on. Then everything should be functional, should go in line with the activities of daily living. What are the, not just measuring at level of function or structure, that this patient has an impairment of this, has impairment of muscle strength, he has a weakness. Then if you improve strength, how can that strength translate to activities that the patient be able to do? That will always be the target. Then we go into holistic approach. Make sure you look at the patient holistically. What is, like I said last week, you look at the role of the individual in his family, role of that individual in his workplace, in the community. What is that patient wanted to achieve? He's going to lose income because of that problem. He's going to lose his role as a father. He's going to lose his. She's going to lose her role as a mother, or as a head of an organization, and so on. So everything should look into. We just don't look at patients as patients, but to look at them as humans, as holistic. What other aspect of their life is involved? Then you also use stage of motor control and motor learning. To make sure that patient is we aim for stability, we aim for mobility, we aim for mobility on stability, and we make sure that those things translate to skills, and those individuals have learned that skills, they have become automatic. Then that's when we have achieved what that patient is supposed to achieve in our clinic. So the assessment should be based on, just like mentioned, is not just the level of impairment at the body structures, but we also look at the limitation and the activities that we can train. Then we also look at the restriction and also the participation we can train for that individual. But looking also at the contextual factors and the personal factors, like I've mentioned. Then this is a summary of the assessment. We'll also look at the assessment briefly. So we have mentioned philosophy. We have also mentioned, as part of the PNF concept, there is also principle. So what are these principles? The principles are the supporting, are supportive at guiding the motion by grip and appropriate resistance. These are basically some of the things. Is to make sure the patient is participating in the exercise. So that is why we have these basic principles. And what are they? They are the stimulation of exteroceptors. How do we stimulate the exteroceptors? How do we stimulate the proprioceptors? And you see sometimes procedure is just a part of the concept on its own, or it is under basic principles. As I have here in my text here, we have procedure under basic principles. So what are these stimulation of exteroceptors? How do we stimulate them? Is through tactile stimulation. How do we have that? Is through manual contacts and a desired lumbrical grip, as we can see on the picture there. This is most of the time how you hold the various body parts or the various limbs when exercising. You can also make contact the body part of the patient with some other environments, like the couch or the wall, and some other things. The patient is making contacts to stimulate the exteroceptor. So what are the goals of the tactile stimulation? Is to stimulation of the patient's skin receptors, facilitation of direction of movement, patient feeling of protection. If you hold the patient, he feels safe to move the limb. If he doesn't have that feeling of safety, he'll be able to move it appropriately. Then it's also that you could also add resistance through the tactile stimulation by the lumbrical grip, the hand grip that you have. Then we have the next one, which is auditory stimulation. You stimulate through verbal command or verbal contact. When patient, first of all, you give instruction to the patient, you talk to the patient to make sure that he's understanding, and sometimes the patient might not be doing the appropriate thing. You also stimulate the patient. Go on. If you want to encourage him, or it's something that you want to correct, no, this way, or something like that. So through verbal contact or command. What is the goal of this verbal or auditory stimulation is to draw patient attention on the motion that is expected to perform, just like what I've explained. Usually short to simulate motor activity, and it's usually short and clear. It's not something we have to be speaking very long English that the patient will not even comprehend. So it's also to relax the patient. If the command is to relax, you say, okay, now relax, or let's move, something like that. And also to analyze the patient's behavior and ability to participate in logical conversation. Some with cognitive impairments will not be able to follow through this instruction. So we also have so this is an example of command. There could be preparation, there could be action, there could be correction, like I've mentioned earlier. So stimulation of exteroceptors, we have the visual stimulation. So it's stimulation that you have to look at the patient and see what is his response. Is it somebody that is just enduring pain? He doesn't want to show that he's feeling pain, but you see from the way he's squeezing the face, he's responding that he's having pain. Or you are giving too much resistance, you're able to know through that. And the patient also making contact, because there is a rule that all through the patient should be making contact, should be looking at through visual cueing, should be looking at what you are doing. He should be looking at what he's doing. So all those contacts should be there all the time while you are carrying out those exercise. So we know that, yes, people learn by watching. We could see how children learn from their parents, learn from peers, learn from friends. We also have other approaches in neuro. For example, we have the task observation, mental practice. They all have to do with visualization. And that's why visual stimulation is very, very important. It's very key. Then we have, yes, I've already discussed this. Then we have the stimulation of proprioceptors. So how do we stimulate that? Is usually through resistance. The resistance we give could be manual, could be from the environmental, could be from the hands of the therapist, could be from the weight of the body of the individual, could be from TheraBand, could be from spring, could be from many other instruments that we can use. Could be from the wall, could be from the floor the individual is lying down, or the mat, or the couch. So, but this resistance is usually in three different, it's usually in different types of muscle contraction. That is isometric contraction, or eccentric contraction, or concentric contraction. That is the two isotonic contraction. Then it's usually three-dimensional, because when there is movement in the PNF pattern, for example, we have not just flexion, but we are supposed to have, for example, in a shoulder pattern, we don't just have flexion, but we have flexion, adduction, and external rotation. So the shoulder will not just go into flexion, it will go into three different movements at the same time. So sometimes there is also application of traction, which will improve muscle contraction, or we apply approximation also, which will also improve muscle contraction and also stimulate the proprioceptors. So this resistance, they are usually optimal. They are not resistant that you give too much to the patient that he or she cannot move. So they are applied in all components. So when there is this three-dimensional movement, the resistance should be across all the three dimensions. flexion, adduction, and external rotation. Not just resistance to flexion, but resistance to all the 3 dimensions. What is the goal? Is facilitation of muscle contraction, improvement of motor control, improvement of sensation and motion awareness, and increase in strength. Yes, then we have stretch, which you have initial stretch, which we are going to look at that elaborately in one of the techniques. It's also just to stimulate proprioceptors, and it's also a technique. So you could give stretch at the beginning of a movement to make sure that the muscles are prepared to contract more, or you be giving restretch all through the movement. Then the procedure. We've talked about philosophy. We have talked about the stimulation of the what do you call it, exteroceptors, and the stimulation of the proprioceptors. Then we'll now look at the procedure before we look at the pattern. So we have mentioned the basic principles. We have mentioned philosophy. We have talked about the basic principle. Under basic principle, we have talked about stimulation of exteroceptors. And we are now talking about stimulation of proprioceptors. Then we'll look at the procedure. So what are those procedures for the application? So the procedure involves movement patterns. They involve timing. They involve body mechanics of the patient and that of the therapist. We'll see, and I've demonstrated last week, we could see how the therapists need to always stand or sit by the patient, also in diagonal. Like we know, most of the movement are in diagonal, so the therapist also should be in diagonal position for him to be able to effectively apply those techniques or patterns. Then we have the timing, which I also described timing, which means the various sequence of movements that we have to carry out to complete a certain movement. For example, we have the upper limb pattern, which we have movement in shoulder, we have movement in elbow, we have movement in forearm, movement in the wrist, movement in the fingers. So what is the sequence of that movement as we are performing that pattern? That is the normal timing. Timing for emphasis is to find out that there's certain problem somewhere along the pattern, be it in the shoulder or in the elbow or in the forearm or in the wrist, and concentrate on that particular area. That is timing for emphasis. Then I've already discussed the body mechanics. Then we have irradiation and reinforcement. So the next thing is now the movement patterns. I think this is what is always giving the whole of the problem, is the pattern. So let's look at it carefully, please. Like I said, the patterns are in 3 dimensions: the sagittal, the coronal, and the transverse. Usually there is a rotation. I give example of the the shoulder pattern. We say the shoulder goes into, if you look at the first diagonal, we have shoulder flexion, we have shoulder adduction, and we have shoulder external rotation. So we have rotation, we have adduction, and we have flexion. So we have 3 dimensions of movement. So we have various patterns. We have upper limb pattern, we have lower limb pattern, we have scapular pattern, we have pelvic pattern, we have trunk patterns, and we have neck pattern. We have a combination of these patterns. For example, scapular and pelvic patterns give rise to a lot of a number of trunk patterns. Combination of upper limb and neck patterns and upper trunk pattern will now give rise to upper trunk pattern. We have the lower limb pattern plus pelvic pattern, which give rise to lower trunk pattern. We have combination of upper limb, the 2 upper limb patterns. We have combination of the 2 lower limb patterns. We'll have combination of upper limb and lower limb patterns. So all these things are possible. But first of all, it's understanding this pattern very well. That is what will help in effective application of this PNF approach or concept. So first of all, these movements, as we have mentioned, they are usually in diagonal. And how these diagonal are derived as a result of how we walk. I've explained also last week, when we look at how individuals walk, we work with arm swing. And if you look at the arm swing, it's almost going in diagonal. So the normal pattern of walking, the normal pattern of our upper limb swinging and the lower limb proportion or movement, that is the diagonal. That is the first diagonal. That is how the first diagonal is obtained. You just think of how we walk, how we swing our arms. That is the first diagonal. That is what we call diagonal 1. First diagonal. Then we have the second diagonal, which is supportive. You want to throw something, you want to hit on something, that diagonal will come and augment the other diagonal. You are playing golf, you want to hold on a ball, you want to do. So that is how you obtain the second diagonal. The first diagonal is you just assume how you walk. So that's how you'll be able to remember the first diagonal. You just think of how you walk. You take your arm across to the other shoulder or the other part of the body and back. That's how you have your first diagonal. Then the second diagonal is the supporting diagonal, because you have your first diagonal here and you have the second diagonal here supporting. You want to throw something, you want to hit on something, you want to play golf, you are playing basketball, and so on. So that is it about the how these diagonals are obtained. So that's why we have diagonal 1 and we have diagonal 2, just like how I demonstrated now. However, we have diagonal 1, which I said is an extension of how we work. But we have diagonal 1 going into flexion. We have diagonal 1 going into extension. We have diagonal 2 also into flexion and extension. So that's what made the pattern more confusing and more difficult. We have diagonal 1, we have diagonal 2. That diagonal is not just in one direction or it's just in one place. It goes into flexion and comes back into extension. The same thing with the diagonal 2. So how you're able to name the pattern is the direction of movement. You are going into flexion, so that is the name of that pattern. But you start in the opposite. You are going into flexion. This is your aim. Flexion, adduction, and external rotation of the shoulder. That is your aim. So you start with the opposite. Extension. Okay, so you start with the opposite. Extension, abduction, and internal rotation. You go to flexion, adduction, and external rotation. That is your aim. You want to reach this particular movement. So the end movement is the name of the pattern. And you start from the opposite to reach the end pattern. I hope it's clear. You want to you have let's forget about diagonal 2. Let's just talk about diagonal 1. We have diagonal 1 here, flexion, extension, flexion, adduction, and external rotation, extension, abduction, and internal rotation. So you want to name the pattern you want to apply. You want to go into flexion, adduction, and external rotation. So you start from extension, abduction, and internal rotation. So your name of your pattern will be flexion, abduction, flexion, adduction, and external rotation. So you start from the opposite. Where you stop, that is the name of the pattern. That is the given name of the pattern. Where you start is not the name. Where you end is the name of the pattern. So the same thing, if your aim is to go into extension, you now name it extension, abduction, and external and internal rotation. If your target is flexion, adduction, and external rotation, then this is the name of the pattern. You end here. You start from the opposite and end here. Please, let me just get a response that this is clear. We can move on, because the confusion will just start now. Okay, thank you. Okay, thank you very much. I'm sure we are familiar with this already. Okay, thank you. Yes, I think I can see many responses that this is clear. So I think I will have to move on. What he said is so the audio will not be.
Saan ka session number?
Then slide share of hand.
Yeah.
Slide share. I'm not gonna slide.
Okay. Okay, so now we can it.
Okay.
Yana mami mai it will be
Okay.
recording. Then to later if you want to watch, then it will be small. That's what Apple says. You can just hold it.
The phone?
You can just hold it.
Okay.
Is it okay?
Yes, I can see.
Can see it okay.
Yes.
Okay.
But then the like sample.
Okay.
Yeah.
Amma da shi mana kofan can yana ba mu haske.
Or because I said if we, that's why I said I don't want to go to the other aspect which was displayed on the advert of this particular workshop. It's supposed to be gate facilitation and math exercises, but I believe if we don't have these things clear, we are going to have a lot of problems going there. So
Microphone.
Yeah, no friend.
Is it on?
This one.
okay, so now please can you hear me? Respond.
Can use the earpiece of my phone.
The right message.
Earpiece.
If they have sent message that they can hear me.
Say yes, sir.
So please, can you all see me and you can all hear me? Let me demonstrate this. Okay, so let's proceed. I said that the movement patterns are a diagonal. That's one of the signature, key feature or key signature of PNF. This diagonal pattern of movement. And I believe these are also part of the problem. I mean, I won't say problem, but the difficulty in understanding the PNF concept as a whole. So this PNF concepts, the patterns, we have discussed the philosophy, we have discussed this is under the procedure that we are talking about. We are going to talk about the patterns. So if you remember,
Yeah, so we are back.
Dr. Khadija, can you turn the phone into landscape?
Into where?
Turn the camera.
Landscape
Yes,
is better.
yes, it will show.
Okay.
okay. So as I'm explaining, these patterns are diagonal patterns. That's one of the key features of PNF concepts. They are in diagonal patterns. But there are two diagonals. The first diagonal is if we look at how we work. So if we extend this pattern of working, for example, we take the upper limb as an example. If you look at how we work, if you extend this pattern, for example, as you are running, it's more it's more extended into the pattern proper as you are running. So that's first diagonal. If you want to remember your patterns, just think of how you work. That is the first, or how the military are marching. You will see that is the first diagonal. It's easy to remember. If you remember the first diagonal, then you'll be able to remember the second diagonal. So just think of how you work, or how the military are marching, or the force are marching. That is the first diagonal. It's very functional. You want to train for gates, you want to train for math exercise, you want to train for anything, you train for one pattern. You are also training for gates. Because if you have a good arm swing, you also have a good gate pattern. That's one of the things. So, but we are introducing patterns now. So we have, this is the first diagonal. So the diagonal goes like this: flexion, adduction of making shoulder as reference, flexion, adduction, and external rotation. Then going back is extension, abduction, and internal rotation. Flexion, adduction, and external rotation, extension, abduction, and internal rotation. So this is diagonal 1. This is D1. D1 going into flexion, D1 going into extension. D1 going into flexion, D1 going into extension. So how do we name the pattern? This is D1. D1 into flexion, D1 into extension. If your pattern you want to apply is flexion, adduction, and external rotation, that's going into flexion. So that's how you name the pattern. D1, flexion, adduction, external rotation. That's your pattern. But you can't reach this without coming from extension. So you want to apply the one pattern, flexion, adduction, and external rotation. You start from extension, abduction, and internal rotation into flexion, adduction, and external rotation. That will be your aim. So if you name the pattern flexion, adduction, external rotation, it means you are starting from the opposite. You end in the pattern you want to apply, or you have targets in mind. If your target is extension, abduction, and internal rotation, so you start from flexion, you go into the pattern you want to apply. You start from flexion, you go into extension, abduction, and internal rotation. So if your target is now D1 into extension, so you start from flexion, you end in extension. If your aim is flexion, you start from extension and go into flexion. So you document that the pattern you applied is flexion, adduction, external rotation. You start from here and end here. If your target is extension, abduction, and internal rotation, so you document extension, abduction, and internal rotation, but you start from the opposite and reach to the end. That is the one. The two is the other one. I don't want to talk about the two. Let's just talk about the one. So I think I hope now it's clear. Please let me hear a response on this. Let me come back.
No. Efter. Super.
I hope now the explanation is clear. Okay, it is now clear. Okay, I thought the person said it is not clear. Okay, so I want to show us, yes, this is the, let me see another comment. Clear. I can see responses that now the one is clear. Yes. So, but when we look at this D1, we can see in this picture here is going into flexion, adduction, and external rotation. Can we see the slide? Okay. So, but if we will now drop issue of shoulder, we'll start from scapula. There's also gliding, there's also scapular movements. That's when we have the shoulder movement. So the shoulder is going into flexion, adduction, and external rotation. We have also scapular movement. As the upper limb is going into flexion, we have scapular anterior elevation. As it is going into extension, we have scapular posterior depression. As the upper limb is going into flexion, we have scapular anterior elevation. As it's going into extension, we have scapular posterior depression. That is what we are going to look at now. So we are going to look at scapular patterns. As we are going into first diagonal, into flexion, we have anterior elevation, and going into extension, we have posterior depression. Then in the second diagonal, which I didn't explain, if the upper limb is going into second diagonal, if it's going into flexion, we have posterior elevation of the scapula. If it's going into extension, we have anterior depression of the scapula. So I will demonstrate the scapular pattern now. Let me stop the sharing. No? Then
See, last time I was even rushing to finish around 5, around 4, after 4. It's okay. So, as I've explained, just remain supine. As we are going into this is the one flexion, adduction, and external rotation. This is external rotation. It's not internal rotation. There's always confusion. People thought it's internal rotation. When you look at the hand, it's going into external. This is going into internal rotation. This is external rotation. So flexion, adduction of the shoulder, and internal and external rotation. Then we have extension and abduction of the shoulder and internal rotation. But when the shoulder is going into this particular direction, flexion, the scapula moves into anterior elevation. When it's going back into extension, it goes into posterior depression. Here it goes into anterior elevation. The scapula goes into posterior depression. So that gives us rise to what's called scapular pattern. The same thing for the lower limb. We have anterior elevation of the pelvis and posterior depression of the pelvis. But let's limit ourselves to the scapula now. So let's focus on the scapula alone. Yes, we have anterior elevation and posterior depression of the scapula. Like we said, is diagonal. You look at my position also, is diagonal. I'm not standing like this across the scapula. I'm not standing in front across or to the other side. I'm standing also diagonal to allow me to apply the facilitation also in diagonal position. You can see my hand grip also, the lumbar grips that we have mentioned. So anterior elevation of the scapula, posterior depression of the scapula. So you have a patient now. You want to target this D1. You want to improve on the function. As your target is ambulation, gait. If the patient has problem with arm swing already, or is having problem with the function of the upper limb, and you want to train this, but that patient has a problem with the scapula already, you know that the function of the shoulder will not be as effective. The function of the elbow and other parts of the upper limb will not be as effective as possible, because you need this lining of the scapula to have effective movement of the upper limb. I talked about the dynamic stability last time. For joints in the body, they will need stability of a certain joint to allow them to move. For example, you need, I have now my lower trunk stable for me to rotate. If the lower trunk is weak, I can't rotate the upper trunk. So I can't move the upper trunk. The same thing too. If I'm lying down, I can't rotate the lower trunk if the upper trunk cannot be fixed and give me that stability. The same thing with that. You need stability and function. It's a good function of the scapula, of the shoulder, for the rest of the upper limb. You need excellent wrist function and strength for the fingers. You need excellent elbow and forearm function for the wrist and the fingers, and so on. So one of the major things, you start with the scapula. So we have the anterior elevation and we have the posterior depression. But this is just a pattern you have applied. It's just like doing a passing movement of the scapula. You just apply anterior elevation and posterior depression. But there is a technique also that needs to be applied. What type of technique you want? It depends on the patient. The patient has weakness. The patient has problem with coordination. The problem has tightness in the muscles, and you want to relax the muscles. That's when the technique will now come in. And that's how you will see on the poster that there is a different classification of, I've also mentioned at the beginning of the slide, you will see different classification of techniques. There is a lot of variation in various texts, but primarily you have 3 categories. For example, you have agonistic pattern of agonistic techniques, you have antagonistic techniques, you have relaxation techniques where you have both relax and contract relax. In the agonistic techniques, you have rhythmic initiation, you have combination of isotonic, you have replication, you have technique with stretch. Then antagonistic technique, you have dynamic reversal, you have stabilizing reversal, you have rhythmic stabilization. These are the antagonistic techniques. Then you have relaxation techniques, which goes into whole relax and partial relax. When you have pain or when you have tightness, shortening of muscles, then you apply the relaxation techniques. So it depends. Let's start with easier techniques, which are they are not the easiest, but they are easier to introduce before going into the other techniques. When we say agonistic techniques, we only have targets that we want to train. We want to involve only the muscles acting in that direction, acting in concentric or eccentric contraction of that direction. I also want to take time, like I did last week, to explain further. I know we are familiar with isometric, eccentric, concentric, but this is the basic of the techniques. If these things are missed out, we won't be able to understand the technique. So I want to explain now muscle contraction before we go into the techniques. So just just to byline our agonists now. I want us to understand how these agonists, antagonists now come into play. If we say, if our target is bicep muscle, or let's say the flexors of the elbow, that's our target. Maybe it's weak, maybe has a problem with coordination. We want to improve strength or want to improve coordination. We only want to target the flexors of the elbow. We don't want to involve the extensors, that's the triceps. So what do? This is flexion, this is extension. But I want to involve only the bicep or the flexors of the elbow. I will make sure the patient is actively flexing, but when it's time to involve the extensors, we'll now apply a certain change of grip to make sure we are involving. I mean, if you change grip, we are going to involve the antagonist. So we maintain the grip. So we know that there is isometric contraction, of course. If we have resistance, hold resistance, if we have static movements, that's when we have isometric contraction. We have static movements. But if there is movement, changing length or shortening, that's changing length, either shortening or lengthening, that's when we have eccentric and concentric. Concentric is shortening and eccentric is lengthening. But I don't want to involve the antagonist, that is the triceps. What do I do? Then now we have flexion, but let me start with the concentric work of the biceps. So now I'll give you instruction to flex, and I'll be resisting his flexion. That means I'm trying to strengthen the concentric work of the flexors. Then how do I involve the eccentric work of this flexors? Is for me to now extend and ask him to resist my extension. Extend. So here, he's going against my resistance. Now, I'm the one resisting, and he's now I'm resisting. So here, he's resisting my push. I'm pushing him, but he's resisting, but he's giving way. He's pushing here, sorry, he's flexing, and I'm resisting. But here, I'm resisting, he's resisting yes, I'm pulling and it's resisting my pull. I'm trying to extend, but it's resisting it. So here he's winning. Just example, maybe easiest way. Here is winning against me. Right? Here I'm winning against him. Let's go up. He's winning against me here. Then here I'm winning against his resistance. Here I only involve the flexors, concentric, and eccentric. I didn't involve the antagonist. It's only when I now change grip and give resistance to the antagonist, then I'm involving triceps. What I did here is concentric work, sorry. When it's moving against me, concentric work of the bicep of the flexors, then here is going against my resistance. Sorry, against his resistance. Here is against my resistance. Here is against his resistance. That is the eccentric work. Eccentric is like you are dropping something. Like I give example. These are all part of math exercises I give. See, you are asking somebody to quietly sit on a chair. You are involving, because if you do that, you feel tension on your quadriceps. You are not just it's not just the flexion of the the quadriceps are also involved. And like I said last week, it's like that was the time you ask patient to sit down and see patient collapsing. And what you taught is the hamstrings, the knee flexors are weak. Then you go on to begin to treat to strengthen hamstring. And you come back, hamstring is 5. Maybe it's 5 plus. It's 5, then still patients collapse in chair. That's because the eccentric work of the quadriceps was structured. We only look at quadriceps only to flex, but during extension also, sorry, it's only to extend. But during flexion too, that quadricep has to also contract eccentrically to allow for quiet sitting. The same thing I mentioned when you ask patient to squat, you ask patient to sit, you ask patient to do many things. There is eccentric, there is concentric work of each muscle. So that's why we want to involve treatments. Are we looking at within the muscle, eccentric, concentric, or isometric? Or we're looking at 2 muscles, biceps, triceps, or within the biceps, eccentric, concentric, or within the triceps, eccentric, concentric, or between the 2 of them, there's a problem. You need to find out in the patient. Especially for coordination, it has to be eccentric, concentric, most of the time. So now bring us to first technique, which you have as agonists, is rhythmic initiation. Like I said last week also, and many times, that rhythmic initiation is just like you doing passive movement or doing any other exercise. It's to prepare the patient, it's to make sure the patient understood that this is the pattern of movement you want to do, this is the exercise you want to do, this is how you want to do it. These are all part of telling the patient. He's able to do the rhythmic initiation, then you can go to another technique. Like, so it's like rhythmic initiation is like a background for any PNF technique that you want to apply. So we have mentioned D1 into anterior elevation, D1 into posterior depression, D1 into anterior elevation, D1 into posterior depression. So now we want to choose, because we want to apply agonistic technique. So we want to now target which is the agonist. Anterior elevation, let's say, is our agonist, is where we want to train. So make sure it's agonistic technique throughout. We don't make it antagonistic. So we want to apply rhythmic initiation. So rhythmic initiation has stages. First stage is passive movement. Second stage is active assisted movement. Third stage is active resisted movement. Then fourth stage is pre-active. That's where you know whether the patient has learned what you ask him to do. If he's able to do that, then you go to the next technique that you want to apply. You want to give resistance, you want to improve strength, or you want to improve coordination, or you want to relax muscles. You go to the appropriate technique. So we have our agonist, which is anterior elevators. That's the patient should feel the movement. You can feel the movement and moving your scapula into the direction of your eye, into the direction of your face. So this is anterior elevation. This is passive. This is the one scapular pattern into anterior elevation. And I'm applying a technique called rhythmic initiation, which is an agonistic technique. So up. This is passive. Then I will now tell him that assist me. Let's do it together. Now let's go up together. Then you ask him to relax because it's agonistic. You don't want to involve the posterior depression. So up and what else am I continuing to we'll go straight to something.
No, we advise them that let them go back to
The math exercise. I want to have
Okay, so we can continue, sir.
it's like this. Okay.
Okay, extension.
Okay. No, vai.
Well,
Yes, sir. So we have serial element.
yeah.
Maybe also open the windows.
Okay.
It's okay. Is it okay?
When they say the background is dark.
Take down. This. Put on the lights.
Okay, let me turn it.
Because we said it's agonistic, so we don't allow the involvement of the posterior depressors. We only involve the anterior elevators. Up and relax. Up and relax. Up and relax. So the third stage is now resistance. Up and relax. Up and relax. Up. You can see how my position of the hand have changed from giving assistance to giving resistance. And you can see my position is also diagonal, like I said. Go up and relax. Up and relax. Up and relax. Up. Relax. Up. Up and up. Relax. Then the fourth stage, you ask the patient to beat himself. Go up. Up. If he's able to do it, then you can apply the other techniques that you have in mind. You want to train coordination, or you want to improve strength. So we have, let's say now our agonist is posterior depression. Posterior depression. So we have the first stage, which is the passive. Now our target is posterior depression. Move back. Yes. Now the second stage, can you assist me? And relax. Push and relax. Go back and relax. Back, relax. Back, push back and relax. Push back and relax. Push back. Now resistance. Push, relax. Push, relax. Push, 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 relax. Then let's do it. So this is rhythmic initiation. We did to anterior elevation. Now we did rhythmic initiation to posterior depression. That is all in diagonal 1. So that is we don't just apply the pattern. I know most of us sometimes we just say we did PNF, but it's not the application of the diagonal that we did. We will not document our PNF. But what is the technique we have applied? Now is one of it that we have just demonstrated. Rhythmic initiation, which is an agonistic. So now apply rhythmic initiation also, like supine. Now rhythmic initiation to the upper limb pattern, which we have mentioned, is we have flexion, adduction, and external rotation. We have we have extension, abduction, and internal rotation. Flexion, adduction, and external rotation, extension, abduction, and internal rotation. So now let's say our agonist is going into flexion. So start on extension up here. We want to apply now the immediate initiation. So this is the movement I want you to do. Go up. This is it. Doing it passively is supposed to be passively. The first stage of rhythmic initiation. Then we have active assisted. We go up and relax. Up, relax. Go up and relax. Go up and go up and relax. Now, I want to go to the resistance stage. Now, let's go up. I'm going to resist. Let's go up and relax. Let's go up, relax. Up, relax. Up, relax. Up, relax. Then show me the movement. So we are not just applying pattern, diagonal movement. We should know what pattern is. Upper limb pattern is diagonal one. Direction into the agonist is flexion. And we are applying a technique which is called rhythmic initiation. So, like I've discussed last week and many times, what you want to implement now is not just PNF. PNF, what body parts? Upper limb, scapula, pelvis, lower limb. What's diagonal? In what direction? And what is the technique you have applied? That shows that you have applied PNF. So we can now add another technique, which is also agonistic. So we have still on the D1, I don't want us to go, well, we can go to the D2. Still on the D1, we have combination of isotonics. Combination of isotonics from the name. We are combining concentric contraction and eccentric contraction. So you are combining two isotonics, eccentric and concentric. So we now, let's say, choose the agonist again, is the anterior elevation. So we have going into anterior elevation, up, and this is direction of movement. Direction of movement. Then we did passively. Then we now assist. Assuming we want to apply rhythmic initiation before going into combination aesthetic, then we give resistance. Then we do it as the patient to do it really and understand. So now we want to apply a combination of isotonics. Now, the combination of isotonics is you need to have the same tension in the muscle going into eccentric, concentric, eccentric, concentric. You don't lose contact, you don't lose tension. That's when the verbal command comes, where you give instruction. You'll be hearing me giving instruction to him. This is how you do it, relax, all those things. So those are the stimulation of exteroceptors that we have mentioned. And so now I want to treat the anterior elevators. Want to give, for example, there's problem with coordination. That's when you apply combination of isotonic. So we now go into anterior elevation, up. Then ask the patient to hold, not to lose tension. Hold. Now let me move you back, just like what I did with the biceps initially, while demonstrating eccentric, concentric muscle work. So now up. Let's go up. It's going into concentric work of the anterior elevators. Then hold. Now let me move you back gradually. You are giving way. Let me win against your movements. Yes, hold, and up. You can see going into concentric, hold, and gradually going back into eccentric of anterior elevators and concentric of concentric and eccentric. The name is simple. Or you are combining eccentric and concentric. That is, you are combining the two isotonics. That's called combination of isotonics. You can also do it for the posterior depressors. Now, sorry, relax. So push and you go back. This is eccentric. Push. This is eccentric. And let me move you back gradually. Let me win against you. Now push. Let me take you back slowly, slowly back, slowly back. Push. And push. This is concentric. And slowly this is eccentric. Push. This combination of isotonics, difficult anterior elevation and posterior depression. So let's try for the upper limb pattern also. This one, oh, it's still okay. So we now have the upper limb pattern D1 into flexion. That is our aim. Now we want to apply a combination of isotonic into flexion, adduction, and external rotation. So now let's go up. Hold, pause. Let me move it back gradually. And up. You see, I didn't change my grip. Hold. Now let's go up, push against my resistance. Now let me move it back gradually, gradually, gradually up. And gradually back, up. For this combination of isotonics. I didn't change my grip. You see, I was not moving in and doing this and changing grip. I was focused only on the agonist, which is going into flexion. That's combination of isotonics. We could do that for the extension. We push. And now I'll move you, resist, and push. Now you resist, you resist, you resist, push. Now you resist. Yes. This into extension and into flexion. We apply two techniques now. So we look into pattern one, flexion and extension. We look at one also scapular, anterior elevation, still pressure. We also look at two techniques, rhythmic initiation and combination of aspects. So yeah, I'm rushing to this. I don't know if there's anyone with question. Maybe you can type. I'll do that if there's a question. Okay. My internet is maybe more. Just check for it. If somebody has typed, if somebody has typed a question.
Can you connect in like? Can you connect in like? Is that okay? To take people to the church. The church.
Okay, a change of power setting. From low power usage to the battery has removed the charging. Yes. Any question, please?
Any question?
Yes, don't check the comment section.
So as we can just see in the picture here, we demonstrated the anterior elevation of the scapula and posterior depression of the scapula, which all of them are under the first diagonal, which we have flexion, abduction, and external rotation, and we have extension, abduction, and internal rotation. And these are some of the uses of all these scapular patterns. Yes, for upper limb impairments or for gait preparation of the upper limb. We could see also is also for trunk exercises, back pain, shoulder problems, and so on. You can apply this. The same thing with the posterior depression also, preparation for walking, preparation for upper limb activities, mat exercises. Yes, like I said, these are also used for mat exercises. Then we have various other things. So this is D2, and I've just talked about the types of muscle contraction. We have the isometric and isotonic. I discussed the isometric briefly. I also discussed the isotonic. I discussed the concentric and the eccentric muscle contraction. And I've talked about the techniques. I said there are generally 3, but it depends on the text. There are different classification. And also the names I've mentioned, you could see that could be a different name. But when you read into it, you see that they are the same application or procedure. And I've mentioned under agonistic technique, we have rhythmic initiation, we have combination of isotonics. I just demonstrated these 2 now. We have replication, we have technique with stretch. Under antagonistic technique, we have dynamic reversal, we have stabilizer reversal, we have rhythmic stabilization, which we have discussed all of this last week. It's only relaxation techniques that we have not discussed last week. So we'll look at relaxation techniques, also hold relax and contract relax. I've already explained this rhythmic initiation, that it has 4 stages or 4 steps. Passive movements, which you also have the assistive stage. Then you have the resistance, then you have the free active. And these are the goals. Learning and automation. Like I said, before applying any other technique, is good you apply rhythmic initiation. The patient understand that this is what you want to do. All these patterns, because when you have patients, it's more difficult to apply these patterns. If you're practicing on yourself and if you're a therapist, it's easy, but you have patients, they don't even know what all these things. So you have to use the terms, the explanation for them to get it better, then you'll be able to apply. So for learning and optimization, for normalization of rate of movement and rhythm of movement, improvement of sense of movement and regulation of muscle tone and so on. So you have the passive, just like you had me giving the explanation, feel the movements, let's relax, let me guide you. That's when you have the passive stage. Assistive is move with me, help me with the movement and so on. So like I said, all those instructions we have mentioned at the beginning, they are very, very key for PNF application. Then we have the resisting, work against my resistance or push against me, and all those instructions. The way the patient can understand, especially that we have language barriers sometimes, we have patients that cannot even understand English, so we have to know the appropriate terms in our various language or the language of the place we are working for us to apply this effectively. Then we have the active stage, which the patient will do it himself. You see that the patient is able to do it, then you can go to another step of. Then we have the combination of isotonics, which I just explained. We have the goal is active control of movement, improve in coordination. This is improve in coordination, especially intramuscular. We have the eccentric and the concentric. So intramuscular, not inter. So increased range of motion, endurance. But this is not the best for strength. But it could be for endurance, but not the best technique for strength. So the therapist resists active movement of patient through concentric. Then the patient will now resist through eccentric and so on like that. So that's the combination of isotonic. Then we can look into another technique, which is we can go into the antagonistic technique maybe and look at some of them now, because not just knowing the pattern. If you also don't understand the techniques that we want to apply, it's going to be a problem. We say under antagonistic technique, we have the dynamic reversal, we have the stabilizing reversal. So they are similar. So I think they'll be easier. We take the two together also. So let me look for the explanation for the techniques. Then we'll apply them together. Yes, we have the antagonistic, we have the stabilizing reversal. The goal is in these are the techniques for strength. Yes, increasing strength, stability, coordination between agonist and antagonist. Because in the antagonistic technique, you have agonist and antagonist, both of them involved. But this goes for strengthening, but it's not the best. You have the dynamic reversal as the best for strengthening. So the steps are: it is possible to apply approximation. You can apply approximation to increase stability before starting. So start with better side or stronger pattern. As we have mentioned in the philosophy, we start with the positive approach, then switch to antagonist pattern. Comes without losing muscle contraction. You don't lose muscle contraction. You are going to change grip, but you don't lose muscle contraction. Then you end up with the weaker side. One of the therapist's hands should always be at the contact with the therapist. Then we have the dynamic reversal, which is the same, but in this place there is movement that is going to be involved. So let's demonstrate this.
So out of now, you can see.
Okay. Straight.
Yes.
So we now want to apply different technique. We now want to apply additional technique. We have just seen two agonistic techniques: rhythmic initiation, combination of isotonic. Now we want to apply two other techniques under antagonistic technique: stabilizing reversal, dynamic reversal. You can see different names in this text, but it's the same thing. So anterior elevation, posterior depression. Now because it's antagonistic, so you can change grip. If you remember, our target at the agonist, unique initiation, combination of isotonic, we are almost targeting all the time is the agonist. For example, our agonist is anterior elevation, will remain there. If it's posterior depression, will remain there. But now this time around is antagonist. So you have to change grip to involve the antagonist, just like what I demonstrated with elbow. I changed grip to incorporate the triceps. So this is also similar thing. So we have let's start with the stabilizing reversal. So we said one of the principles or the philosophy is of PNF is you start with the stronger side. So where is the stronger side? For example, is posterior depression. So we start with posterior depression. We're going to give resistance push, so hold. But this is stabilizing reversal, so there is no movement. So just push. No, there is no movement. You just, so I'm supposed to give an optimal resistance and also going to give a certain push that will not involve movement because it's a stabilizing reversal. So push. So push. So now up, push up. Now both sides are involved. Push up. Hold. Now push back. See, there's contact all the time. I'm changing grip, but that tension should be maintained all the time. So push up. Yes. You can see that there is no movement. Push up. And that's stabilizing reversal. So we started with the stronger side, which is assumed to be posterior depression. Now we now end with the weaker side, which is anterior elevation and relax. So that's stabilizing reversal. So the dynamic will involve movements, range of motion from anterior elevation. So that's one of the differences of the two. So now dynamic reversal, you see, push, hold. So push up, yes. Hold, push back, hold, push up, and relax. Stabilizing reversal, like movements, just resistance, optimal resistance. You don't give too much resistance, usually optimal resistance, and there is no movement in the pattern. But in dynamic reversal, you see there is range of motion. So that's two antagonistic techniques. So when you are applying PNF, which pattern you are applying, which diagonal, to which direction you are applying, what is your target? Is it agonist? Is it both antagonists you want to involve? Is it weakness? You want to improve strength, or is it you want to improve coordination? So that will give you choice of which technique you want to apply. So you look at the pattern, you look at diagonal, which are direction, and you look at also the technique you want to apply. When you have all these things plus other things about the procedures, that's when you are fully applying PNF concept. So those are two techniques. Those are diagonal one of upper limb or scapular pattern. So we can now look at the lower limb also. The lower limb, we have said, is just like the normal walking we do. That's where we have the same thing too. As we are walking also, we have anterior elevation of the pelvis, and we are going back, we have posterior depression of the pelvis. Just like in the scapula, we have anterior elevation of the scapula, we have posterior depression of the scapula. Same thing with the pelvis. While you are walking, you want to kick ball, or you want to walk, or you are parading, marching, you have anterior elevation of the pelvis, and you have posterior depression of the pelvis. So the same thing. So the same thing, you want to apply rhythmic initiation also. For example, our target is anterior elevation now. That is the agonist. So say this is the movement. Position. This one just stop. Yes. This one just stop.
No, it's from his network
It's internet.
and it's about.
So this is direction, anterior elevation. So here, up and down, those feel the movements. Then now say, let me move you up and relax, to return you back, up and relax, 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 up. That's active assisted. Then you want to give resistance up and up and up and up, 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 plus, up, plus. So show me the movement. This the limit initiation, anterior elevation, D1, anterior elevation. So we have also the limit initiation, D1 into posterior pressure. So this is, we are now pushing back and we return the person back. So this is passive. Remember, the limitation has 4 steps: passive, active assisted, active resistance, and free active. So this is passive, then active assisted, then relax. You turn him back up, and so you push down and let me go down, relax, down, relax, down, 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 and relax. So now push against, yes, relax, push, relax, push, relax, push, push, push. So now let's apply combination of isotonic. Now let's push up, and no, you are not relaxing. You have to maintain the tension. Up, hold, and yes. Sorry, let's go all the way. Yes, then up. Yes. I will move you back and up. You go against my resistance. Now it's against your resistance. You are resisting, I'm taking you back and up and back, up, back and up. This combination of isotonic. We are going eccentric, eccentric, eccentric. So we can also apply the same thing while we push and let me move you back slowly and push. Yes, push and yes. Up. Now it's pushing against me and I'm pushing against him now. It's pushing against me and I'm pushing against him. This combination of isotonic. This pattern also, scapular, pelvic patterns, they are also trunk patterns. They are also part of mat exercises. Let me just introduce now. They are also part of mat exercises. Let me just mix in. So this is also part of mat exercise, because if you train this, you're also training kids, because you are training for better upper limb function through the scapular pattern. You're also training for better lower limb function through the pelvic pattern. And you can do this on the mat. Yes. You can see here while we are going up is helping towards rotation. The same thing when it's pushing towards rotation. So it's strengthening the lower trunk, while the scapular pattern is strengthening the upper trunk. So you could do this on the mat also. And we have also what we call, which I've discussed last time, is combination of patterns. You can combine patterns. You can combine upper limb pattern. We have not done the 2 yet, but let me demonstrate combination in the trunk pattern or in the scapular and the pelvic pattern. So now you can decide to combine all the D1. We have not done D2, but let's look at the D1. The one we have done. You can combine posterior depression of the pelvis and anterior elevation of the scapula. For example, you can apply, let's say, the technique of, you can apply dynamic reversal, you can apply, you can apply a combination of isotonic. So, okay, let's take posterior depression. But this, yeah, this is for training of the trunk and also for coordination of the trunk and many other things. So also to help in rolling of patient and many other things before you do math exercises. So posterior depression and anterior elevation. So push my hand, yes, and push on this hand. Yes, push. Yes. Or you can have anterior elevation and posterior depression. Push on my hand here, and yes. Push. Push. Yes. It's our pattern. The scapular pattern, the one into anterior elevation, posterior depression, various techniques, because the pelvic patterns into the one anterior elevation, posterior depression, various techniques on their own are also part of math exercises. Combining them also is also part of math exercise. You do that on the mat or even on the couch. So this is a combination we have just done of D1 anterior elevation, D1 anterior elevation and posterior depression. D1 posterior depression and anterior elevation. You can have D1 anterior elevation and anterior elevation of the pelvis. Yes, both going up. Push here against my push against my hand. Yes, and relax. Push. Going anterior elevation, posterior depression and posterior depression. Also, you can also have that combination. We have not come to the two yet. Combining the two, I will also define the various combinations. I said last week that combinations are in various forms. We have, yes, they are bilateral patterns, or yes, they are symmetrical, or they are asymmetrical. They are symmetrical, reciprocal, or they are symmetrical, just symmetrical, going in the same direction. They are asymmetrical only, or they are asymmetrical reciprocal. It's the diagonal that will determine, and its direction of movement that will determine that. I don't want to do with those things. Then, what else should we maybe we take two. Let's take second diagram. Okay, now let's look at second diagonal. Okay. Yes. Let's look at the second diagonal now. Yes, let's demonstrate. So we can now see the second diagonal. We can now see second diagonal, which we have flexion, abduction, and external rotation of the shoulder. Then we have that is going into flexion and going into extension, like I explained. We have flexion, abduction, and external rotation, and we have extension, adduction, and internal rotation. Don't worry about all these lengthy things. So we could see here on the picture, this is D2 going into
starting from one direction and ending with another direction. So we have flexion, we have extension, adduction, and internal rotation. Then we have flexion, abduction, and external rotation. This is a summary of it on this, and this is also another. This is more detailed information, but this is just a summary of the two pattern. The pattern you see colored with blue, that is blue there. That is the second diagonal. So we have flexion, abduction, and external rotation. Then we have extension, adduction, and internal rotation. So
Worship.
This various combinations in various positions to find all sitting into videos, standing. We are doing that. Like yes, it's more practical relation with you. I think this is the first time I have not taught it.
So we can continue. We can continue.
So yeah. So like I demonstrated at the beginning, we have the one as you are imitating the way you walk. That is because diagonal flexion and extension. Then you have the two, which is supporting. For example, you have the one together here, you want to do something, you want to pick up something. The two is always supporting to the one. It's not just you want to throw something, it's not part of the gate pattern. You think of the one is the gate pattern, the other one is other activities, supporting activities, or you want to throw on something, usually is the D2. Yes. So you have the D2. Going into flexion, going to flexion, abduction, and external rotation. This is external rotation. Yes. I know this rotation is always giving the difficulty. You think this looks like internal. Yes. When you go back to the shoulder, you have the shoulder head, then you understand whether it's internal or external. but this is external rotation.
External.
This is internal rotation. Yes. We have external rotation. So this is the 2. We have talked about the 1, which is just like how we are working. But this is the other pattern that is supporting, let's say. You want to throw on something, you hold something together, you want to hold the ball, you are throwing, and all those things. So this is the 2. We have flexion, abduction, and external rotation. We have extension, adduction, adducted, internal rotation, like this. So that is another pattern. I mean, diagonal. That's the second diagonal we are now applying. Second diagonal. So we have this abduction, flexion, abduction, and
Holding of diagonal position.
sorry, I'm carried away. You know, which usually most of the time it's called diagonal. Yes, so we have extension,
Abduction.
sorry,
Second diagonal.
this is the 2, sorry. Yes, we have this is flexion, abduction, external rotation. We have extension, adduction, and internal rotation. Flexion, abduction, and external rotation. Internal rotation, adduction, and extension. Flexion, abduction, external rotation, adduction, extension, adduction, and internal rotation. Right? Obviously. So as we are doing this now, what's happening to this? We have posterior elevation of the scapula. Scapula is elevating posteriorly. We do this is depressing posterior. This one we have anterior elevation of the scapula, posterior depression of the scapula. Here we have posterior elevation, anterior flexion. Anterior elevation, posterior depression. So anterior elevation, scapular pattern of the D2. Of the D1, it's anterior elevation, posterior depression. But for D2, it's posterior elevation and anterior depression of the scapula. Anterior depression, posterior elevation of the scapula. So my position will now change. We are going into posterior elevation. Go up. Now, this is the direction of movements I want you to feel. Up and down, up and down, up and down, up and down, up and down. So our agonist now want to apply rhythmic initiation. our agonist now is into posterior elevation. So up and relax, up and up, relax, up, relax, up, 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 relax, up, relax. So now resistance, push, relax, push. You can see my biomechanics also. You can see the position of the patient, everything, how you can easily apply resistance to diagonal pattern and so on. You see also how I'm changing my grip when passively, when giving assistance, and also when giving resistance. So push, relax, push, 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 and show me. So this is anterior elevation, sorry, posterior elevation, the 2 scapular pattern. Posterior elevation, the 2 scapular pattern. So now we have posterior anterior depression, the 2 scapular pattern. This is the movement. This movement I want to feel. Movement. So now help me go down and relax. I'm returning him back passively. Let's go down and relax. Down, relax. Down, relax. Down, relax. Down, relax. Down, relax. Down. Now I want to give resistance. Yes. Push, relax. Push, 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 relax. This is the initiation. We can also give combination of isotonics, dynamics, reversals, stabilizer reversal. Depends on what the patient has implements. We give the technique. Let's look at combination of isotonics. So push, and let me push you back slowly, gradually, and push up, and let's go back. Let's go back all the way. Let's go back all the way. Push, push, push. Sorry, I'm pushing you now. Let's go back all the way. Up and back. Up and back. Up and up. Up. So there is what we mentioned earlier as approximation. So you can apply approximation, then you ask the patient to push. Something like this. Approximation, ask patient to push. Approximate, ask patient to push. So that is the 2, posterior elevation and anterior depression. So the same thing also for the pelvis. The 2 we have anterior depression, posterior elevation, anterior depression, posterior elevation. So depending on which we choose as our agonist. So we can now see we have posterior elevation, we have additional combination we can do now. We have posterior elevation and we have posterior elevation now. Right? We can now combine posterior elevation of scapula and posterior depression of pelvis. So we push here. Is for coordination.
Posterior elevation of the scapula and
Posterior depression.
okay. Posterior depression.
Depression of
Okay.
yes,
pelvis.
this is T1 of pelvic pattern. And you get it. Posterior elevation. And D2
of scapula.
posterior elevation. Push and relax. Relax. Push and relax. Push. This will prepare individual into rotation.
Yes. Yes.
So this also is math exercise you can also apply. So push and relax. Push and push. So this is anterior elevation. This posterior depression, sorry, posterior depression and posterior This is posterior
Elevation of the
elevation,
scapula.
and this posterior depression of the pelvis. Yes, push and release. Push, push. This especially means preparing somebody for rolling or rotation. Nice. Rolling, rather. Strength. So you can also add many combination. Depends on what you want to apply.
Once you understand
Once you understand the individual movements, combine diagonals, they can combine.
That's what you need.
Yes, depends on what you want the patient to achieve. So now, I said this is a combination of pelvic and scapular pattern. You can also combine lower limbs and combine upper limb. You've seen at the picture as we are going through. I was showing a picture of both Dorothy Voss and Cabot and Herman Cabot. They were even combining upper limb and lower limb. That's very much advanced. So there are various combinations you can make, and those are very much more functional. So the various combination is you have bilateral upper limb pattern, for example. It means two upper limb patterns are involved. So they are bilateral upper limb. But are they symmetrical or asymmetrical? What made them symmetrical is, are you going on the same diagonal? If they are going on the same diagonal, then they are symmetrical. They are going on different diagonal, then they are asymmetrical. For example, let's take D1 for both of them. This is D1 for this. This is D1 for this, right? Yes. This is D1 for this. This is D1 for this. So if you have both of them going together in the same diagonal and the same direction, right? Same diagonal and the same direction. So this is symmetrical. This is symmetrical. This is just bilateral, symmetrical. D1. This is bilateral, symmetrical. But when you have from the same diagonal, but different direction. Yes, they are going in different direction. This one is coming, then that one going. You have symmetry, you have bilateral, symmetrical, or reciprocal. They are reciprocating. This one is going the bilateral, symmetrical, reciprocal. But you have bilateral, I hope we are getting it. We have bilateral. The audience here were here last week, so we have so please let them not rush you, so you can respond. They all been here many times, so so this symmetrical, reciprocal. But you have asymmetrical, which is not reciprocal, that they are going in the same direction. So this is now. This is the one. This is the two. They are going in the same direction. They are asymmetrical, but going in the same direction. Right?
That's not asymmetrical.
Normal asymmetrical. Then we have normal asymmetrical that they are reciprocal. Now let's see it. Okay. Asymmetrical reciprocal. You get it now. So, what we have mentioned under the stimulation of exteroceptors, we mentioned visual cueing, visual inputs. So all the time we are applying these techniques. Be it single, whichever one, patients have eye contact, should follow the movements, should look at the fingers, look at the hand, all through. So you should be looking at. So you should turn your neck and watch. Yes. So if you can take your leg even up and flex and see and go back. So here you are combining upper limb and neck pattern. Oh. So this is the reference. Your hand is the reference. The fingers. So, watch. Yes. Which other technique we are applying? We make sure the patient is involved. We say the patient has to be involved all the time. Has to be active. If it is mental, it should be participating. So they be involved. So we have a technique now which you can combine. This is a neck, of course, neck technique, diagonal flexing and extending, also flexing and extending, like you were doing. We are combining neck pattern now. So you can combine, we have what is called chopping and lifting. Just like you hold a poplar, you hold an axe and chop off a wood, for example. So you have chopping and you have lifting. Yes. Bilateral asymmetrical pattern of upper limb. You can have what's called chopping and what we call lifting. So in these two, you have the leading arm and you have the lagging or following arm. So you have the leading arm now that is taking you up for lifting. And you have the leading arm taking you for chopping. You understand? So let's try it. You can do it in lying position, mat exercises, in sitting, and if it is standing, yes, as I'm doing it, or also in sitting or in lying. So you have the leading arm, you have the lagging, following arm. Yes, so your eye watching. Yes. So, but it depends on the technique you apply. That's when you know what you are actually applying, whether it's lifting or it's chopping. Yes, when you involve the agonist here as coming from flexion, sorry, coming from yes to flexion, yes, from extension, flexion, right? By resist or flexion, yes, that is lifting. When I give resistance, it's also involve the upper trunk while giving the resistance. Yeah. So you can have also chopping, which you can ask the patient to even involve the trapezius, the upper muscles. Yes, up. Yes. You can feel, yes. We are involving the trunk also. Even sometimes irradiation, all those things can come through that. Then you can also combine the lower limb. I think we didn't demonstrate the lower limb. You want another stretch or the one kind of stretch. The lower limb, the one and the two. Yes. So we have one, we have flexion, adduction, and external rotation. Okay, so when I look at, I just remember that we have not demonstrated the lower limb patterns. Yes, we need to do that. We just demonstrated the pelvic pattern. The D1, like I've said, is just like you are walking. Also, you are marching, or you want to kick on something, kick on board. So that is the D1. So we this is. So we have D1, which is flexion, adduction, and external rotation. Just like the upper limb, flexion, adduction, and external rotation. Then we have the opposite, extension, flexion, abduction, and external rotation. So flexion, adduction, and external rotation. We have extension, abduction, and internal rotation. Flexion, adduction, external rotation. We have extension, abduction, and internal rotation. So the same thing, you want to apply a technique in limbic initiation, combination of isotonics, or the various techniques you want to apply. You can do that. Then you have D2, which is flexion, abduction, and internal rotation. We have the opposite movement, which is extension, adduction, and external rotation. So we have this position, which is here extension, adduction, and external rotation. And we have flexion, abduction, and internal rotation. This is internal rotation. Yes. This is external. This is internal rotation. So we have extension, adduction, and external rotation, right? We have flexion, abduction, and internal rotation. Extension, adduction, and external rotation. Flexion, abduction, and internal rotation. That's for D2. So as you can see here now, this is we want to now combine the two, D1 and D2. Yes, they cannot see this slide. So this is, can you see it? Maybe to the edge of the maybe how they can see it here. Sit down, sit down. So this is bilateral symmetrical. Yes. And which direction also in a spine line, take almost up. This is a sitting position. The lower limb is a bit more difficult than the upper limb. Yes. So if it's the same, if it's bilateral asymmetrical, we'll have something like this. Yes, some bilateral, yes, asymmetrical. Just like in the upper limb, yes, bilateral asymmetrical. Yes, for the same direction. And we have different reciprocal. So we can also combine. So you can also involve the trunk. For example, we give resistance. Okay, you resist my extension. For example, let me extend, resist. No, you are going to resist extension. Yes.
Of course, even the abdominal,
So now the trunk, you are involving the lower trunk. Yes. This is bilateral, asymmetrical, yes, pattern. We are involving the
Trunk.
lower trunk, yes.
of course. The abdominal.
Various combination. This is also part of what do you call it? Exercise. You'll come back, we don't go straight to math exercises.
Like an announcement. Make an announcement, you are going to do.
Okay.
Go to the
Until,
math exercises, gate facilitation.
so we are going for break.
Don't know what
So,
time.
sir, when are we coming back?
What time is it?
Just 30 minutes.
We'll just take 30
We
minutes.
have a lot to cover.
Let's come back around 2.
Okay, so we are coming back around 2.
Maybe
We're
let's
going
have
for a
30
break.
minutes.
Because people have to add